Hello, everyone. This is Jolene. Today, Zaza and I will go over enteral and parental nutrition, both you need to know for the RD exam. Here is our recommended studying method. If you have seen it in our other lectures, feel free to skip ahead. But if you haven't seen it, here is what we recommend. Watch this lecture as many times as you want while you have access. Make sure you download our worksheets. You can decide if you want to fill out that worksheet during the lectures as we go, or you can do it afterwards as a memory test for yourself. Additionally, we have supplemental materials in a PDF. This is information we didn't have time to cover during our lecture, but is still relevant for your RD exam. So make sure you download them while you have access. And lastly, when you're ready, test out your knowledge with our RD exam practice questions. Use a timer and see how long it takes you to finish them. This is meant to give you that slight taste of the RD exam. Here are our learning objectives for today. First up, we have to understand the purpose of enteral versus parental nutrition. That includes their indications and contraindications. Second, we'll learn the types of access, formula types, closed versus open systems, and delivery methods. And lastly, we'll learn how to calculate for both EN and PN. We'll go over the basic calculations in detail. These will serve as foundation for both your RD exam and your clinical rotation. I'll be teaching you enteral nutrition or EN during the first half of our lecture, and Zaza will teach you parental nutrition during the second half. Let's get started. So let's do a quick recap for EN/PN and differentiate the two. Enteral nutrition or EN refers to any method of feeding that uses the GI tract to deliver nutrition. It can include a normal oral diet, the use of liquid formulas, and supplements via mouth. And lastly, a feeding tube. The entry site of this feeding tube is called Enteral Access, and we will discuss it in just a bit. On the exam, remember that if your gut works, use it. On the other hand, parental nutrition or PN refers to the delivery of nutrition via your blood vessels, specifically your veins, never your arteries. Zaza will cover more details of PN later in this lecture. When a patient is admitted in an ICU, how do you determine the correct nutrition delivery? Here, we made a decision tree for you to follow. The first question you have to ask is, does my patient have adequate nutrition? To figure this out, you need to estimate energy needs based on your hospital's protocol. It can be indirect calorimetry, Mifflin, activity factors, quick methods, and sometimes the kcal is already prescribed by a doctor. On your RD exam, use whatever information provided to estimate energy needs. We have already taught this in detail in lecture 6, so make sure you understand how to calculate nutrition intake before we move forward. Now, if your patient has adequate nutrition, continue with oral diet and reassess regularly. If your patient does not meet energy needs, this is when you need to find the right feeding methods. This brings us to the second question. Does your patient have a functional GI tract? If the answer is yes, the GI is working, ask another question. Does my patient have a healthy appetite and is physically able to eat? If yes, then continue with an oral diet and add on supplements as necessary. If no, GI is working, but my patient can't eat, then we need EN via feeding tube. On the flip side, if the GI is not working, we will need to decide which PN is more appropriate. To figure this out, ask yourself, does my patient need only short-term support and is not severely malnourished? If the answer is yes, choose PN via the peripheral vein. If not, choose PN via the central vein. I hope this decision tree can help you, and this is a good time to pause the video and fill out your decision tree on your worksheet. Now that you are more familiar with enteral nutrition, let's talk about its indications and contraindications. For adults, if you have inadequate oral intake for 7 to 14 days, EN is needed. This prolonged inadequate intake can be caused by many reasons, such as dysphagia, GI disorders preventing adequate nutrition absorption, increased nutritional needs in certain medical conditions, such as burns, trauma, surgery, or cancer. And lastly, impaired mental status or consciousness. For kids, EN indications include malnutrition, poor growth, and their inability to orally consume more than 80% of their caloric needs. Overall, the main indication for EN is prevention and treatment of malnutrition. Now, on the other hand, when is EN not recommended? The main contraindications for EN are non-functional GI tract and hemodynamic instability. More specifically, conditions such as high output GI fistula, bowel obstruction, paralytic or prolonged ileus, and mesenteric ischemia prevents our ability to give EN. As a reminder, a fistula is an abnormal connection between two parts inside of your body. Ileus is the inability of your intestine to contract normally and move the waste out of your body. Mesenteric or bowel ischemia is defined as the sudden loss of blood flow to the small intestine. EN in patients with bowel ischemia, necrosis, or massive GI bleeding can make a bad situation even worse. Currently, consensus among experts determines hemodynamic instability as a contraindication to both EN and PN. But once clinical stabilization is achieved, feeding can be initiated, preferably by the EN route. When it comes to EN, you need to select the right feeding route, also called the Enteral Access. Let's go over each of these terms and make sure you can quickly recognize what they are. For short-term EN, we have NG, ND, and NJ tube. Notice that they all start with the word nasal, meaning the feeding tube will be inserted down your nose. You can also see this tiny tube on our top diagram. Furthermore, the end point of this tube indicates the second half of its name. For example, nasogastric indicates the tube begins at the nose and ends at the stomach. Nasoduodenal indicates the tube is ending at the duodenum. And lastly, nasojejunal is ending at jejunum. Now, how do you know which nasal feeding tube is good for your patient? If your patient has a working stomach, choose an NG tube and use that stomach. But if the patient cannot tolerate the NG tube, switch to ND or NJ tube with doctor's approval. So, why are these three tubes for short-term EN? In general, these are the least invasive tube feeding types. But the downside is when you insert a tube down your nose, you can be pretty uncomfortable and potentially develop ulcers in your nose. On top of that, this nasal tube can also move to the wrong places and bacterial growth is more likely to happen. Now, moving down to our bottom graphic, for long-term EN, we have gastrostomy and jejunostomy. Notice that both words end with stomy, meaning that we'll need to make a surgical opening on the abdominal wall to insert these feeding tubes. PEG or G tube goes directly into the stomach. Jejunostomy or J tube goes directly into the jejunum. The doctor will decide which tube is better, but in general, J tube is better suited for patients with high risk of aspiration who require post-pyloric feeding. Now that you have a better understanding of the enteral access of the feeding tube, let's discuss the formula bag that connects to the feeding tube. We have both closed and open systems. So how do they differ? Closed or ready-to-hang enteral feeding systems utilize a pre-packaged formula in a container that's sterile and ready to use. This formula container can be used for up to 24 to 48 hours, reducing the risk of bacterial contamination and spoilage. Hence why this closed system is more convenient and safer. On the other hand, open enteral feeding system uses formula from cans or bottles that is hand poured into a feeding bag and then administered through a feeding tube. Because this system involves mixing formula in the open air, it is not sterile and has an increased risk of bacterial contamination. This is why the hang time for an open system cannot be more than 4 hours. After you've picked the enteral site and choose either open or closed feeding system, you will need to select the right EM formula. In real life, each hospital will have a variety of eating formulas with different kcal densities and nutrient compositions. Some formulas will be standard, such as Gevity 1.0 with 1 kcal per 1 milliliter, whereas higher kcal density formulas, such as Petmin 2.0, will have 2 kcal per milliliter. For the RD exam, you need to understand the difference between polymeric, elemental, and specialized formulas. Let's start with polymeric, also known as standard or isotonic formula. These formulas contain whole proteins, complex carbohydrates, and long chain triglycerides, meaning that the nutrients are intact and have not been broken down. These formulas are suitable for patients with intact digestion and absorption capacity. Next up, elemental formula. These are extensively hydrolyzed, meaning they will deliver 100% of their protein through free amino acids. In other words, these proteins have been completely broken down into their simplest form, amino acids. Similarly, semi-elemental formula contains amino acids of different length, including peptides. The proteins here are partially pre-digested. An example is Petmin AF. Both elemental and semi-elemental formulas will contain simple sugars and MCTs. Do you remember why MCTs are helpful? These are fats that do not require pancreatic lipase or bile acids for absorption. Overall, elemental and semi-elemental formulas are more pricey and are suitable for patients with malabsorption or impaired digestion. Lastly, specialized formulas. They are designed for specific medical conditions like diabetes, renal failure, or liver disease. On top of that, we have immune modulating formulas with omega 3s, arginine, glutamine for trauma patients. We also have inflammation modulating formulas with omega 3s and antioxidants for sepsis. Just from their names, you should know that these specialized formulas are the most expensive formulas. So they're only implemented in patients with specialized needs. On the RD exam, you may need to quickly choose an EN formula with limited clinical information. We've listed some quick tips for the following diseases. If you have acute pancreatitis, start with standard formula. Many recent studies have shown that the standard formula is just as good as elemental when it comes to treating acute pancreatitis. And this is the current guideline from Aspen. So the cheaper standard formula is the preferred method as long as the patient can tolerate it. If you have chronic pancreatitis, use elemental or semi-elemental formulas, especially if the standard formulas are not tolerated. Moving on, if you have acute kidney injury, start with standard formula. But if you have chronic kidney disease or if you're on dialysis, use Nepro. the specialized formula for CKD. And lastly, if you suffer from short bowel disease, try elemental formula for better absorption. Please keep in mind that how you select EM formulas in real life may be different from what we just taught here. Each hospital has its own in-house or branded EM formulas and their selection criteria. So make sure you follow that in real life. Now, no matter what formula you choose, remember the feeding tube is pretty small and you have to do water flushes to prevent clogging. Per Aspen guideline, flushes need to be done at least 30 milliliter for every 4 hours for patients who are on continuous feeding. For bolus feed patients, they need 30 milliliter of water flush before and after each feed. By now, you know how to pick the right EN formula. The next question is, how much and how often do you need these formula? There are 5 common feeding methods, including bolus, continuous drip, intermittent drip, cyclic feeding, and transitional feeding. Let's tackle them one by one. First up, bolus feeding. This is when you provide formula via a syringe or gravity drip over a short time, around 4 to 10 minutes. You'll need bolus feeding several times a day with a minimum 3 hours in between. As you can see in our graphic right here, the highlighted neon green portions are the feeding time. They're meant to give you a quick visualization to help you memorize these different feeding methods. Now, the pros for bolus method is it is simple and convenient. There's no pump required, and you can be more flexible with your daily life. But on the flip side, since you're getting fed pretty fast at once, this may cause gastric distension or discomfort, and there is an increased risk for aspiration. Second, we have the continuous drip method. This is when you provide formula at a constant rate for a long time continuously. Feeding will take about 16 to 24 hours long. So basically, you're getting fed day and night. On the RD exam, if they do not specify the time frame for continuous feeding, assume they mean 24 hours. The upside for this method is you can get steady nutrient absorption with less risk of gastric distension. But the downside is you will need an infusion pump with you at all times. The third method is called the intermittent drip. This method is somewhat similar to a normal eating schedule. For each feeding, you will provide formula via a pump or gravity for around 30 to 40 minutes. You will need several feedings a day with 4 to 6 hours in between. The upside is you don't need a continuous infusion, so you can be more flexible. But the downside is if you get a lot of feeding at once, you may still experience gastric distension and aspiration. Now, cyclic feeding. This is when you provide EN at a continuous rate over 8 to 16 hours. This method is typically used at night when you are asleep. Cyclic feeding can be used along with eating food by mouth if you cannot eat enough. The method is convenient if you can't do tube feeding during the day because of your treatment schedule. The downside is it requires nighttime monitoring and it may disrupt your sleep. Lastly, the transitional method. As your GI function improves, this method helps you transition from PN to EN or from PN to eating by mouth, also known as PO. You will be gradually getting EN while tapering off PN. You'll be on PN until at least about 60% of the caloric requirement can be achieved via EN. This method prevents refeeding syndrome and facilitates the transition to EN or PO. But the downside is it requires close monitoring and adjustment of nutrient intake. So it is often done in a hospital setting. Before we jump into EM macros and calculations, I want to remind you two things. First up, levodopa, also called Cinemet. Since protein reduces levodopa's efficacy, avoid taking levodopa when administering large protein doses via foods or EN. Next up, gastric residual volume, GRV. Historically, it was recommended to check GRV every 4 hours during the first 48 hours. And after that, every 6 to 8 hours for patients who are not critically ill. If GRV is higher than 500 milliliter, it was recommended to hold feed to reduce aspiration. Now, in real life, this practice of checking the GRV is not always done in hospital due to newer guidelines. There is very little evidence for its efficacy or indication that this practice reduces aspiration pneumonia. But for the RD exam questions that were written before this new guideline, you still need to remember holding feed when GRV is higher than 500 milliliter was intended to reduce aspiration. Finally, let's talk about EN macronutrients. This will allow us to understand the most basic calculations for EN. First up, carbohydrates. Each gram of carbs contain 4 kcal. Remember, most EN energy comes from carbs, which is why the diabetic patients need a specialized formula. Next, proteins. Each gram of proteins contains 4 kcal. Remember from our lecture 1, proteins are made of amino acids, and every amino acid have at least one nitrogen. Mathematically speaking, we need 6.25 grams of proteins to get 1 grams of nitrogen. Remember this as it will come in handy for any nitrogen calculation you might need in the future. Moving on, we have lipids, which provides about 9 kcal per grams. Please keep in mind this is just an estimate. The EN lipids can be made from all sorts of oils, such as corn, soy, canola, and even fish oils. Lastly, water. Most EN formulas contain 70 to 85% free water, and sometimes your hydration status need to be met with a small amount of additional water. I will show you an example on how to calculate that additional water in a couple slides. Now, if free water is not provided in tube feed formula on the RD exam, you can use the approximate estimation based on your EN kcal density. As shown in this table, table 1.1, standard formula with 1 kcal per milliliter have approximately 85% free water. Higher kcal formulas with 1.5 kcal per milliliter have around 75% free water. Finally, the very high calorie formulas with 2.0 kcal per milliliter have around 70% free water. As you can see, the general trend here is the higher kcal, the less free water content. The RD exam may ask EN questions in all sorts of ways. In general, you gotta understand the basic calculations first before you advance. Today, we will go over how to find the EN total feed volume, how to find the total kcals in the EN formula, how to calculate macronutrients of the tube feed, and lastly, how to calculate free water flushes and check your hydration status. Let's tackle how to find the EN total feed volume. There are multiple ways, and here are the 3 most common methods. If you know the EN rate and how long it is administered, simply multiply the two to get the total feed volume. For example, if your patient is getting cyclic feeding for 10 hours at night and the feeding rate is at 40 milliliter per hour, then the total feed volume will be 40 times 10 equals to 400 milliliter. Moving on. The second method is very similar in logic. If you know the volume of each bolus feed, times that with the frequency, you will know the total feed volume. Lastly, if you know the total kcal prescribed, divide that by the nutrient density of the formula. You can also get the total feed volume. Let's try out a practice question. A diabetic patient needs about 1400 kcal per day. His prescribed EN formula has 1.1 kcal per milliliter, 50 grams of protein per liter, and 80% free water. How much formula does he need in a day? This question gives you more information than you need. To solve this problem, you need to first find the relevant data first. This patient needs 1400 kcal per day. His formula density is 1.1 kcal per milliliter. So we can use the third method mentioned above. 1400 kcal divided by the nutrient density at 1.1 kcal per milliliter equals to 1272.7 milliliter. In general, when you're solving EN questions like this, make sure you keep track of your units. This will help you get the right answer the question is asking. Let's tackle how to find the total kcals. There are multiple methods. First up, by rearranging the formula we just learned, we will have total kcal equals to total feed volume times nutrient density. Sometimes on the exam, this total kcal is already given, but other times the patient might have a prescribed formula which has a designated nutrient density. For example, Jevity 1.5 has 1.5 kcal per milliliter. Nutrient 2.0 has 2 kcal per milliliter. You can then use the nutrient density times the feed volume to find your total kcal. Second, you might be given the amount of macronutrients in EN. Once you find the exact grams of proteins, carbs, and fat, you can easily calculate the kcal from each macro. Add them all up, you can find your total kcal. I will go over an example in more detail in the next slide. Lastly, you might have a question where you need to determine the appropriate total kcal based on the patient's estimated energy needs, and then see if the current EN meets his nutritional needs. In that case, how do you find the patient's energy needs? Well, it will depend on what information is given in question. For example, the Mifflin-Syndrawer equation requires gender, weight, height, and age. But quick methods will have kcal based on activity level, such as a patient with minimal activity who is bedridden will have energy needs around 25 kcal per kilograms of their body weight. But a patient with daily intensive exercise will need around 45 kcal per kilograms of their body weight. We learned how to estimate energy needs in lecture 6. So if you need more clarification on this, please review that lecture. Now, without further ado, let's do a practice question. If your patients need between 1800 to 2000 kcal per day, which formula and rate would be the most appropriate? Well, to solve this, you need to calculate each option and choose the best formula. For example, option A is continuous feeding. So 50 milliliter per hour times 24 hours gives us the feeding volume. Use that times the nutrient density at 1.2 kcal per milliliter will give us the total kcal. Repeat this for option B, C, and D. We'll find that option B is the only formula that is within the 1800 to 2000 kcal per day range. So B is correct. All right, let's go over how to calculate macronutrients. First of all, if the question gives you a specific formula for the EN, the nutrition facts of this formula should also be provided. So checking this information will be your step 1. Then you can calculate the kcal of macronutrients based on the total feed volume. Let's do a practice question together. A patient received nutrient 1.0 at 80 milliliter per hour and is on continuous feeding. How much energy is provided from proteins, fats, and carbohydrates? To solve this question, we need to first locate the nutrition facts of this formula. As listed above, nutrient 1.0 at 1000 milliliter has 1000 kcal, 40 grams of protein, 34 grams of fat, 148 grams of carb, and 832 milliliter of free water. The total feed volume is 80 milliliter per hour times 24 hours, which give us 1920 milliliter. Then we need to calculate the grams of each macronutrient to get to their kcal. For example, there are 40 grams of protein in 1000 milliliter of nutrient 1.0. So 40 grams divided by 1000 milliliter times 1920 milliliter will give us 76.8 grams. This is the amount of protein for 1 day for this patient. Since protein has 4 kcal per grams, 76.8 times 4 equals to 307.2 kcal. This is the kcal from just protein. You can then repeat the same process for both fat and carb. Pause the video, check your math against what we wrote here, and see if you have calculated correctly. Now that you're familiar with calculating EM macros, let's learn how to calculate free water, flushes, and hydration status. Let's start with free water. If free water is not provided in the tube feed formula, use our table 1.1, which allows you to estimate the free water based on formula kcal. But if free water information is provided, the total free water is free water percentage times the tube feed volume. For example, how much free water is in 1920 milliliter of nutrient 1.0? Remember, per the nutrition facts, nutrient 1.0 at 1000 milliliter has 832 milliliter of free water. So this is pretty much simple algebra. 832 divided by 1000 gives you the free water percentage. Times that by 1920 gives you 1597.4 milliliter. This is the total amount of free water in that formula. Now, how much water flush is needed for your patient to prevent clogging? Like we said before, per Aspen guideline, flushes need to be done at least 30 milliliter for every 4 hours. For bolus feed patient, they need 30 milliliter of water flush before and after each feed. So let's do a practice question. How much water flush is needed daily for a patient on continuous EN feeding? Well, continuous feeding means he is likely getting fed for 24 hours a day. So 24 hours divided by every 4 hours times 30 milliliter is 180 milliliter. This patient would need at least 180 milliliter of water flush to prevent clogging. Let's talk about hydration status for the EM patients. Step 1, you need to calculate the adequate hydration. This can be estimated from energy. For every kcal of energy, you will need 1 milliliter of water. Sometimes the hydration amount is limited and prescribed by a doctor. This is especially true if a patient is on fluid restriction. Step 2, you want to check how much water is already provided via free water and flushes. Step 3, calculate the additional water to meet the patient's hydration needs. Let's do a practice question. A patient is prescribed with continuous nutrient 1.0 for 1920 kcal in a day. Same scenario as before. How much more water is needed to meet his hydration needs? Step 1, let's find the adequate hydration. Since this patient is getting 1920 kcal of formula, we will need 1920 milliliter of water for him. Step 2, find the free water and flushes. Well, from our previous calculations, you already know that in that 1920 milliliter of nutrient 1.0, there is 1,597.44 milliliter of free water. On top of that, you will be giving water flushes for 180 milliliter since he is getting continuous feed. This leads us to step 3. How much additional water is needed to meet needs? You can calculate this by using adequate hydration minus the sum of free water plus flushes. The result is 142.56 milliliter. This is the additional amount of water this patient needs to meet his hydration needs. That was a wrap for our EN introduction and calculations. You can check out our ENPN supplement for more practice questions. And if you're just getting started preparing for your RD exam, please use our free RD exam self-assessment tool. It has 50 questions covering all 4 domains. The best part of it is we already posted the explanation video. We went over the logic and all the answers one by one. So this is a great free resource for anyone who is just getting started for their RD exam. You can find our self-assessment tool on our website linked right here, www.preptable.org/resources. Best of luck studying, and I will see you in our next lecture. Bye.